Okay, so role of CT angiography in indication for revascularization, equivocal or forgotten. So I would say it's neither equivocal nor forgotten. And I'll try and prove my point here. So with no disclosures except the perceptible conflict that I am a die-hard fan of and proponent of CT angiography. So what is the dogma? So we all believe that coronary artery disease is bad. Why? Because progressive atheroma causes significant stenosis, and stenosis causes reduction in flow or ischemia, and that causes events. That's we all believe, and we have believed. So, if we believe in that dogma, then obviously the answer is simple. And the algorithm has to be that let's find stenosis because it causes ischemia, find ischemia because it causes events, treat stenosis because that will reduce ischemia, and fixing stenosis and reducing ischemia will automatically mean less myocardial infarction and lesser deaths. Where does it all come from? And as David just said, that those trials of 1970s and 1980s, when we had those mega surgical trials and the beginning of the randomized trials, in fact, that it was demonstrated that when we had the triple vessel disease or we had the two vessel disease predominantly with the involvement of the left anterior proximal descending artery, on a long-term basis, the surgical revascularization did better than the medical therapy, which was optimal for those days. And not only that, that there was a freedom from angina, as well as an improvement in exercise tolerance, which was long-lasting. Now, where did this 70% occlusion come from? And the 70% stenosis was based on the elegant trials of Lance Gould, where we had demonstrated that at 70%, was the inflection point where there was a decrease in the coronary flow reserve. But that was the single vessel normal coronary arteries in dogs, where we found that there was a decrease in the blood flow at 70% stenosis. So the question whether in those days the lesions were same as we see now, and was that optimal medical therapy really the optimal medical therapy? And there are some very elegant studies from Michael Davies from those times when we realized that the lesions at that time were pretty different. You'll see huge necrotic core here, thin fibrous cap, something what we call as the high-risk plaques. Even in those cases where it was the stable lesion, you will still see there was a huge necrotic core. That was the absence of statins. Thick fibrous cap in this particular case. And obviously, the optimal medical therapy was not there. And it needed some kind of a courageous attempt here so as to reinitiate the trials in this century when where we have tried the optimal medical therapy available to us today and compare them to the revascularization. And the courage trial, which is one of the landmark trials of our time, we did see that there was no difference in large number of patients when the optimal medical therapy was compared with the PCI and optimal medical therapy, and there was a long follow-up in these cases, suggesting thereby that we should reduce the number of revascularizations, and it indeed reduced the number of revascularization in the country and beyond. Now, at the same time, you would see that the FAME group of studies were coming up, which demonstrated that the importance of the functional ischemia or functional importance of these lesions, and demonstrated that the patients who were stratified based on the reduction in the functional, the patients who had functional reduction, these were the people who did better on revascularization. So people with less than 0.8 FFR in the FAME2 trial for and when they were compared with the PCI and optimal medical therapy, the outcomes of the PCI and optimal medical therapy was significantly superior, and the trial was stopped at 7 months' time because they had met the primary endpoint. Now let's look at the two y-axes in the courage trial and the FAME2 trial. And here you would see it is the survival free of the death or myocardial infarction, while in the FAME2 trial it was cumulative percent incidence of death, myocardial infarction, or need for revascularization. And essentially, it is the need for revascularization that drove the results in the FAME2 trial for the short term. However, even if you look at the long-term results of FAME2 trial, you would see that the results maintained, and over the next 5 years, quite like what the courage trial we had seen, but here you would see that essentially the results is the need for revascularization, and that represents the overall results of the FAME2 trial even at 5 years' time. And if you look at the cardiac death or myocardial infarction, there was essentially no difference. So now, in a very elegant editorial by Dr. Bill Bowden, who was the principal investigator of the courage trial, he tried to reconcile there and demonstrated that even in the patients with courage or in the courage trial, you would see that the need for revascularization was essentially the same as in the FAME2 study, suggesting thereby that these two studies were essentially the same. And this was the time that we were really looking forward to having the ischemia trial. And we thought that we would get all the answers now with the ischemia trial, specifically that we had the CT angiography ahead of it, and we excluded those patients where probably the equivocal results would have been coming from. So in such a situation, again, we would find that the results were the same, that there was no difference in the medical therapy compared, or the conservative therapy compared to the invasive therapy in these cases. However, in a very elegant subsequent paper that we saw in circulation, there was a significant difference in the spontaneous myocardial infarction in these subjects. So there was the spontaneous myocardial infarction rate in the conservative arm was approximately 6% compared to the invasive arm, which was about 3%, with the absolute risk reduction of 3% and the relative risk reduction of more than 52%. So the question that arises here is that did ischemia demonstrate failure of revascularization to reduce MI? Or, more important question, whether the failure of ischemia testing to guide revascularization. So, is there something else here? So when we look at the FAME2 study, and as we saw that at the 5 years, there was still no difference in the death, myocardial infarction, but there was a significant difference in the need for revascularization. However, in the optimal medical therapy group, there were 50% of people who did not die, did not have myocardial infarction, or did not need revascularization. And what does that suggest us? That we need to identify those people who are not likely to have the events on the optimal medical therapy, and identify those people who are likely to have events when they are given the optimal medical therapy. And in a very elegant, another study which comes from the FAME2, which was presented by Dr. Habib Samedi from Emory, and was published in JACC in 2018, that they looked at the wall shear stress in the optimal medical therapy group, a small subset of patients, and then they had matched them in those patients who did not have events versus those which had events. They did the 3D reconstruction of their coronary vasculature, and by looking at the wall shear stress, stress, they demonstrated that those who had significantly greater wall shear stress had much worse outcome, and it was approximately the number that would represent those subjects who have had events in the optimal medical therapy group versus those who did not have optimal medical therapy group, and demonstrated that it does much better than FFR, implicating that there is a possibility that it is the composition of the atherosclerotic plaque or the stenosis which is probably important in such a situation. So let's put it all together here and see what could be the evolving paradigm in this case. So all these earlier studies of these surgical mega trials, that all those lesions which are beyond 70% in triple vessel disease, we probably should be intervening in those, and revascularization will be better, highlighting the anatomical importance of stenosis. Now, what do we think now? And that is that by FFR, and that was the part of the guidelines, that we should be able to take a bite of that, approximately 33% of the people who have the functionally insignificant lesion, we probably could take them off, leaving only about 66% of subjects who would require intervention. Now, if you look at the FAME2 data, and you see that 50% of the people do not develop events on even the optimal medical therapy, is there a way that we would be able to find those subjects, take them off, and only leave the revascularization for 33% of people? And if we invoke Dr. Samidi's trial here, would there be a possibility that we should be looking at the FFR positive and the high-risk plaques in that particular case? So what are the high-risk plaques? We all very well know, and specifically for Mount Sinai, it is embedded in our DNA here. Dr. Fuster, thank you. And so we have this large necrotic core, a very thin fibrous cap that ruptures here and exposes the thrombogenic necrotic core to the lumen here, and you would see the thrombosis in this particular case. And if we say that the plaque has all these characteristics, but the fibrous cap, which is the thin inflamed fibrous cap, which has yet not ruptured, then it is a plaque which is vulnerable to rupture, as you would see in the middle panel. Huge necrotic core, full of cholesterol crystals, inflamed and very thin fibrous cap in this particular case. The two other lesions here, the right upper panel and right lower panel here, you would see that these are also the vulnerable plaques, huge necrotic core, thin fibrous cap. Again, huge necrotic core, thin fibrous cap. What is the difference in these three lesions? In this case, the lumen is not affected at all. In this case, the lumen is modestly affected, and the lumen is critically affected. And it is essentially that up to about 40% of the vascular area, when it is occupied by the necrotic core, that is the time when it becomes vulnerable to rupture, and that is after which the plaque starts to impinge on the lumen. Until then, it is all positive remodeling, and this compliance and the promiscuity of the vessel is dependent upon how much of the necrotic core would it be able to accommodate before its external elastic lamina stops the plaque to further positively or paradoxically remodel. And that will be when the hemodynamic forces would start to interact, and the possibility of FFR working with the morphology of the plaque would become important. So now, how can we non-invasively identify such plaques? And this was our attempt back in 2005, when we had started to look at the CT angiography as the assessment of the high-risk plaques. And as we had pathologically seen, this was about 300 cases that we had looked at with Dr. Renu Vermani, that red is the plaques which are ruptured, blue are the ones which are vulnerable, and green are the plaques which are stable here. You would see that the two most important things which are amenable to the non-invasive imaging that come to the front when the recursive partitioning analysis is used is the inflammation and the size of the necrotic core. And as you can see here, that we had started to compare it with the intravascular ultrasound at that time, and demonstrated that by looking at the Hounsfield unit densities, we should be able to identify the necrotic necrotic core quite well. And in our very recent presentation, which was a multinational, multicentric study, which was the Reveal plaque study, we have demonstrated that now with the automated algorithms, we should be able to identify the plaques which are necrotic core rich, and there is a distinct relationship between the intravascular ultrasound verified total plaque, calcified plaque volumes, non-calcified plaque volume, and the low attenuation plaque volume. That is the plaques which are rich in necrotic core. In our another study where we had looked at the patients who had had the acute coronary syndromes, who had the low risk and had presented to the emergency rooms after 24 hours of their chest pain, and who could be taken to the CT angiography before we took them to the cath labs, we demonstrated two features as which were responsible for the acute coronary syndromes. And as you would see in this subject with unstable angina, 51 years old male, who has now about 50% luminal occlusion here, but there are two distinct features that come across. One is the presence of this low attenuation plaque, which is less than 30 Hounsfield unit densities here, and shown by the red arrows, and then the positive remodeling, which is shown here by the yellow color, which is more than 110% of the proximally normal coronary artery. On the other hand, those plaques which which did not demonstrate positive remodeling and the absence of the low attenuation plaques were considered to be the stable disease. And at that time, when we wanted to call them as soft plaque and all, the reviewers did not allow us to do that because we did not have an evidence that these are the plaques which are eventually, or on prospective way, they are resulting in an event, and they wanted us to give it a very non-specific name, and we called them as two-feature positive plaque, that is those which had positive remodeling and the presence of low attenuation plaque, and now it has become a lingo as two-feature positive plaque, and if you find the third one, you call it a three-feature positive plaque or whatever it is. So when we took it further, so now 1,000 patients with a minimum of 2 years follow-up, we identified that the two-feature positive plaques had 45 times higher likelihood of having an event as compared to those which had two-feature negative plaques. And the two-feature negative plaques had less than 0.5% likelihood of having an event over the next 2 years as compared to 22.5% likelihood of having an event when you had the two-feature positive plaques. And we thought we have found the answer. And essentially, the greater the remodeling index, more the total plaque volume and the necrotic core volume, greater was the likelihood of having an event, and earlier was the likelihood of having an event in those cases. However, when we follow it up for 10 years, 3,000 subjects, 10-year follow-up, we find that yes, the high-risk plaques are indeed the high-risk plaques. And when you look at the non-high-risk plaques, yes, up to about 2 years of time, as we had seen earlier, there is no likelihood of having an event in these cases. But then some of these cases would indeed develop the high-risk plaque features, and over a period of time, there are approximately 2% likelihood of these plaques also, they are likely to have an event. That is, these plaques become the high-risk plaque over a period of time. And what exactly it is which identifies these plaques? So when we look at about 500 of these subjects where we had the availability of two CT angiograms at an interval of 1 year, we found that those which demonstrate the plaque progression are more likely to have an event as compared to those who did not have plaque progression. And again, if you will see that if the first plaque was the high-risk plaque and there was a plaque progression, 35 times higher likelihood over and above what we had expected in those cases to have an event. And even if there was a high-risk plaque but there was no progression of the plaque, you would not have an event. And not only that, that it was also lead to the significant increase in stenosis, leading to the hemodynamic perturbances in these cases. Now, at any given time, at any cross-section, when we look at the plaques, 10% of the plaques are high-risk plaques and 90% of the plaques are non-high-risk plaques. So, likelihood of having an event at 10 years from the high-risk plaques is exactly the same as that from the non-high-risk plaques, essentially leading us to believe that we need to do something else than just repeating the CT angiograms over a period of time. Now, here you would see that in this particular case, that as the plaque progression continues to occur, and this was the reanalysis that we did of the NXT trial from Bjarne Nogard, that you would find that the two things which determine the FFR are one, the QCA, and the second one was the low attenuation plaque in these cases. And it seems that it is the Glagovian hypothesis again coming true here, that when there is a low attenuation plaque, even if there is no significant stenosis in the lumen, the possibility is that once the plaque expands to the maximum, there is a likelihood that the vasodilators would not, at least in the epicardial vessels, would not be as effective as they would be when the plaque is able to extend. So, now that all the automated features selection as well as the possibility of their assessment has become possible, we have now demonstrated that the use of these softwares can give us the results almost immediately. And there are certain factors which become important at the vessel level versus at the plaque level. Now, if there is a plaque progression, why exactly is the plaque progression occurring? And there are three important mechanisms that we have seen over the periods of time. The first one is the presence of inflammation. And as we saw that Dr. Fuster did talk about it earlier, and David also just presented about the possible use of colchicine and others, which is establishing the role of inflammation more and more in the plaques. So sometimes the inflammation is significantly higher. It could be out of proportion to the LDL infiltration. And as you can see that now it has become possible to identify these by the OCTs. And later, I know Greg is going to be talking to us about the micro OCTs and all, where we should even be able to see the individual macrophages and possibility of the inflammation in a much better manner. CT angiography now, by looking at the coronary fat attenuation index in the pericoronary areas, is also able to demonstrate that the attenuation in the pericoronary area, as you can see here, that is different from the epicardial, because once there is inflammation in the plaque, the fluidity of the perivascular fat changes. It becomes more watery and less lipidic. And basically the Hounsfield units, when this is, the Hounsfield units are greater here as compared to in the epicardial plaque, that demonstrates, that suggests as a surrogate marker for the presence of plaque inflammation. And as suggested by Antoniadis and his group from Oxford, and when they reanalyzed the Scott Hart data, they demonstrated that whenever there was the difference between the epicardial fat and the pericoronary fat, it was one of the important determinants of the adverse events in the Scott Hart patients. The second important mechanism of the plaque progression is development of the vasa vasorum. As you can see here, these are the experiments from Amir Lerman's lab from Mayo Clinic. As you can see here, that when when the fatty diet was fed to the porcine model, you'll see that there was a significant proliferation of the vasa vasorum. Now, why does that occur? And this was our paper back in 2005 in NEJM, where we had tried to demonstrate the importance of vasa vasorum. And here you can see that once the thick plaque, the vessel wall starts to become thicker, it requires the proliferation of vasa vasorum, so that the hypoxia and the induction of the HIF1 alphas and VEGF and all, in response to that there is an increase in the vascular supply to the vessel wall. And as you can see here with the Eulich staining, that there is a significant increase in the vasa vasorum. And as the vasa vasorum pierces through the smooth muscle cell layer and comes to the neointimal parenchyma, it loses all its smooth muscle cell cover, and only the endothelium and the pericytes are left, and these vessels become leaky. They lose the macromolecules in the plaque milieu, and the most important component of is the red blood cells, which are released in this area. And imagine if these vessels, which are friable vessels, if there is a plaque, if there is the neovessel rupture, and there is intraplaque hemorrhage in these cases, and bolus delivery of the red blood cells in these cases. The red blood cells, to remind you, is the richest source of free cholesterol in the body, other than the cells which are covered by the myelin. So here the free cholesterol to phospholipid ratio is maximum, and you could see that they will all turn into the free cholesterol crystals in the vessel wall, and the free cholesterol to cholesterol ester ratio of the vulnerable plaques is significantly higher as compared to the cholesterol ester alone, which is brought by the LDL in these cases. Vasovasorum can be identified by the intravascular optical coherence tomography, as well as by the delayed plaque enhancement by CT angiography, as we showed earlier. Now, the third important mechanism is the subclinical plaque rupture and healing. So the plaque rupture and healing cycles, as you can see, that the subclinical plaques would rupture, the less stenotic plaques would rupture. It would be a subclinical event, and as the red blood cells come on top of it with the platelets, they get embedded, they get re-endothelialized, and eventually, because of the red blood cells, there are multiple necrotic cores which develop in the plaque, and there is the plaque progression in these cases. And this was from Dr. Fuster's data, which Dr. Fuster earlier had shown, that the people who have more than 2 risk factors, almost all of them will have some level of the atherosclerotic plaques, and essentially gives a chance that these are the subjects who are likely to have the progression of their plaques, and with the progression of the risk factors. Now, in our very recent study, which just got published about 2 weeks ago, where we looked at about 745 subjects who had had their CT angiography and then were subjected to the invasive coronary angiography, and the decision was taken by the physicians based on their invasive coronary angiography. They did not have an access to the plaque composition or the functional importance of those lesions. And we, by looking at the CTs, identified the FFR CT, as well as the presence or absence of the high-risk plaques. And as you can see here in these 745 subjects, that those people who had the FFR, which was abnormal, as you can see here with the green color, basically they had the worse outcome. Those who had high-risk plaques, they had worse outcomes. But when we put them together, that is the FFR, which is abnormal, as well as the presence of HRP, there was significantly worse outcome in these cases. Now, when you go on to the vessel level determinants here, you'll see that the CTA and FFR, CTA, FFR, and the revascularization in those where the FFR was abnormal, these subjects did better. And similarly, those with the high-risk plaques did better, but statistically not significantly. However, when both of them were combined, that is those who had abnormal FFR and the high-risk plaque, you will see that there was a significant discrimination in this particular group as compared to those who had only FFR abnormal but high-risk plaques were not there, or the high-risk plaques were there and the FFR was not abnormal. So, putting us to propose here that if we look at two things, that is the FFR, which is abnormal, versus those which are normal, and high-risk plaque which is present, or high-risk plaque which is not present. And if we look at these 4 cells, you'll see that the people in this group did better with revascularization. So let me ask three questions here. One, could this represent unsafely deferred group in courage and ischemia study? Two, could this represent appropriately chosen group for FAME2 study? And third, could this have been an alternative population for Prospect 2 study, which I would let Greg address when he talks about the imaging or the intravascular imaging in these subjects. Now, when we look at those who had normal FFR, but the presence of high-risk plaques, in those there was a somewhat better outcome with revascularization, but statistically not significant. Now, again, the questions could be, this was the Prospect 2 population essentially, but could this group be treated with aggressive lipid-lowering therapy instead? And do plaques imminently at danger of rupture need better identification? That is, do we need to find this particular group here? Then the non-high-risk plaque groups, but abnormal FFR, which is our practice these days, there was no difference essentially in revascularization, and the two questions that come are, does this group represent true courage or ischemia proposal, and could this population be safely deferred from the FAME2 indication? And finally, those which are neither FFR abnormal nor high-risk plaques, they obviously would not do well and do not need to be subjected to revascularization. Then just to talk, just a line about the Prospect 2 trial here, and that too the Prospect absorb subset of the trial. And again, I would not talk much about it because Dr. Greg Stone would be discussing about it. But essentially, there is a possibility that we would be, if the plaque is imminently in danger of having an event, specifically if we are able to find those which are HRP positive and FFR abnormal plaques, would that be amenable to the interventional therapy rather than the lipid-lowering therapy? Now, can lipid-lowering therapy really reduce the plaque size or necrotic core size? And here you would see that here is a subject who is 61 years old, subject. He basically had the abnormal CT angiogram. As you can see here, that there is only approximately 50% luminal stenosis, less than 50% luminal stenosis in this particular case, but there's a huge necrotic core. But because of that, the FFR is abnormal. When we maximize the statins, here you can clearly see that there is a significant reduction in the necrotic core size. The lumen remains the same, approximately 25% lesion, but the FFR has completely normalized in this particular subject. Something similar what has been shown by Dr. Kinney in her Yellow 2 and now the Yellow 3 trials also, that with a decrease in the near infrared yellow, you would see that the FFR improves with the reduction in the lipid core burden index. And that even goes further when we add the PCSK9 inhibition on top of the maximized statins, the study which she presented at ACC this year, and the genomics of that are currently being evaluated. So to end, if we look at the primary prevention studies and the secondary prevention studies, and if we put them all together and extrapolate them to reach the minimum or level of zero cardiovascular events, you will have to reduce the LDL level to approximately 55. And if it is the secondary prevention trial, it will have to be down to about 30, something which by slip of tongue David also agreed to. And European Society of Cardiology did have the guts to go ahead and talk about it, because when there is a likelihood of a second CV event within 2 years, they suggested that we should reduce the LDL down to approximately 40. And if it is so, how many people really reach these goals? And if you look at the Da Vinci trial from Da Vinci registry from Cosicre, you'll find that less than 20% of the people receive the optimal therapy. And then coming to the last proposal, which I really admire, and Dr. Fuster talked about that study where the inclisiran is going to be introduced. So basically, Dr. Braunwald, as he suggests, that if at 35, if you are able to add the inclisiran and bring once a year and bring your LDL down to about 50 or 60 just by one shot a year, flu on the left and inclisiran on the right, would you be able to prevent reaching the level of the critical threshold for the atherosclerotic cardiovascular disease and be able to live to 100 without a heart attack? So, coming to the role of the CT angiography, I'd like to conclude that eligibility for revascularization based on anatomic significance of lesions has been debated and made way for establishing the functional importance of luminal stenosis. FAME 2 demonstrated that not all hemodynamically significant lesions require intervention, possibly true courage type of patients. It is important to identify lesions that could be deferred. The possibility of role played by plaque composition has been suggested to be responsible for occurrence of hard endpoints. CT angiography verified low attenuation plaque and positive remodeling best describe high-risk plaques. Novel methods have suggested the feasibility of detection of plaque inflammation by CT angiography. Prospective studies are needed to define the role of plaque pathology in management of chronic coronary disease slash syndromes, whatever you would like to use. That is to define imminently event-prone population of ischemia. Our entire experience has been based on subjectively binary interpretation of CT angiography, and AI-supported strategies for automated quantitative plaque assessment at both lesion and vessel levels are currently being investigated. Thank you.